Why can't I push my stool out? My stool is stuck halfway. What do I do right now? Should I keep pushing, or is that making it worse? What happens if I can't go for days? How do I make myself go fast? If any of those questions are in your head right now, I'm going to answer every single one. But first, 3 things you need to know before you do anything else. The first, what you are experiencing is not ordinary constipation. Something has changed inside the rectum. The stool has hardened to the point where your body's own mechanisms cannot move it. And the longer it sits, the worse that becomes. The second, the instinct you're acting on right now, bearing down harder, straining with everything you have, is one of the most dangerous things you can do in this situation, especially if you are over 60, especially if there is any heart condition in your history. I will explain exactly why. And the third, if liquid stool has appeared in the middle of all of this, urgent, frequent, looking exactly like diarrhea, do not treat it as diarrhea. Taking an anti-diarrheal at that moment can turn this into a genuine emergency. By the end of this video, you will know what is happening inside the body right now, what the correct sequence of intervention looks like step by step, and exactly which signs tell you this has moved beyond home management. Let's start with the biology. The rectum is a muscular holding chamber at the end of the digestive tract. It receives stool from the colon above, holds it, and coordinates a release. The rectal wall contracts, the sphincter relaxes, the stool exits. That process has been happening automatically in your body thousands of times. You have never had to think about it until now. Here is what changes when impaction develops. The large intestine continuously absorbs water from whatever passes through it. Under normal conditions, stool moves through quickly enough to retain sufficient moisture to pass easily. The system works because of speed. When stool slows, when it lingers instead of being expelled, that water absorption continues. The colon does not know the stool is stuck. It keeps pulling moisture out. The mass loses water. It compresses. It hardens against the rectal wall. The window between difficult to pass and physically immovable is shorter than most people expect. In a person who is already dehydrated, which describes a significant portion of adults over 60, stool can harden to a clinically impacted state within 12 to 24 hours, not days, hours. This is the distinction that matters. Constipation is stool moving slowly, uncomfortable, but still movable. Fecal impaction is a hardened mass that the body's normal evacuation mechanisms physically cannot shift. The rectal muscles activate. They contract against the mass. The mass does not yield. The pressure behind it builds. The muscles try again. Your body is not failing to respond. It is responding and meeting something it was not designed to move alone. That is what the rest of this video is for. Fecal impaction does not arrive without warning. It is the predictable end result of several forces that converge in older adults. And most of these forces are already present in your daily life right now, operating quietly without anyone having pointed them out to you as a combined risk. Your bowel is slower than it was 20 years ago. As the body ages, the muscular contractions that move stool through the colon, peristalsis, slow down measurably. Transit time increases. Stool spends more time in the colon. More time means more water absorbed. More water absorbed means stool arriving at the rectum drier and harder than it would have in a younger body. That is the baseline before any other factor enters. Now add reduced fluid intake. Thirst sensation decreases with age, and many people over 60 deliberately drink less because of bladder urgency or incontinence concerns. The instinct is understandable. The consequence is a bowel that is already slow now working with drier material than it should have. Now add reduced movement. Physical activity stimulates the gastrocolic reflex, the nerve signal that drives peristaltic contractions. Less movement means less signal. Less signal means slower transit. If your activity level has decreased, your bowel function decreased alongside it. Now add diet. Softer foods, smaller meals, less fiber. All of them reduce the bulk and moisture content that helps stool move efficiently. And this is where the risk stops adding and starts multiplying. A body that is slower, drier, less stimulated, and eating less fiber is not 4 times more vulnerable. The compounding effect is exponential. Each factor accelerates the others. And in most people over 60, all 4 are present simultaneously right now without anyone having named them as a combined system risk. If 3 or 4 of those things are true about your daily life, you are not approaching impaction as a theoretical possibility. You are already inside the risk window. Now, here is why this matters clinically and why it is not your fault that nobody told you. This is a failure of the conversation that should have happened. The conversation about bowel health as an active management priority in aging, not as a symptom to address only when something goes wrong. That conversation very rarely happens, and the absence of it is why so many people arrive at fecal impaction having done nothing wrong and received no warning. You now know what the forces are. The next step is understanding what not to do because that matters urgently. The instinct is to push harder. Something is stuck. The body demands effort. That demand is overwhelming, and almost everyone acts on it. Here is why it fails and what it costs. The stool is not stuck because there's insufficient pushing force. It is stuck because of what it has physically become, a dehydrated, compressed mass pressing against the rectal wall. Increased abdominal pressure cannot soften that mass. The force has nowhere productive to go. Straining harder is mechanically the wrong tool. The situation does not require more force. It requires a different approach entirely. Now, what it costs when you strain forcefully bearing down holding your breath, a specific pressure cascade occurs inside the chest and cardiovascular system. The vagus nerve activates, heart rate drops. In a younger cardiovascular system, this is transient. In an adult over 60 with any history of heart disease, arrhythmia, or on medications like beta blockers, this response carries real cardiac risk. Fainting during or immediately after straining, defecation syncope occurs through exactly this mechanism. It is documented. It is not rare. In patients already managing compromised cardiac function, the events associated with severe repeated straining can be serious. Every time you strain hard against an impacted mass, you are running a cardiovascular risk. Beyond the cardiac concern, repeated straining causes progressive tissue damage. Hemorrhoids develop under sustained venous pressure. Anal fissures develop from forceful effort against resistance. In severe cases, rectal prolapse where the rectal wall begins to protrude externally can develop from sustained downward pressure. These are the documented outcomes of using the wrong approach over time. The correct intervention starts somewhere completely different, with changing the physical state of the stool itself before asking the body's muscles to do anything. There is a moment in this condition that sends people in the wrong direction almost every time. After several days without a bowel movement, after the pressure, the straining, the waiting, something changes. Liquid stool appears. Urgent, frequent. It looks exactly like diarrhea. The instinct is immediate. Take something to stop it. Do not do that. What is actually happening? The hardened mass is sitting in the rectum, blocking the passage. The colon above it has not stopped functioning. New stool continues to be produced and pushed downward. That stool, still liquid higher up, reaches the blockage and has nowhere to go. Pressure builds. Eventually, liquid seeps around the edges of the hardened mass and exits. This is overflow diarrhea or paradoxical diarrhea. It is not the body resolving the impaction. It is an alarm signal that the blockage has reached a critical level. Anti-diarrheal medications work by slowing bowel motility. In true diarrhea, that is the correct mechanism. Applied to an already impacted bowel, it slows motility, further hardens the mass further, and worsens the situation. In severe cases, adding a motility-slowing agent to a colon already under blockage pressure can contribute to dangerous colonic dilation. If you have already taken an anti-diarrheal before watching this, stop taking additional doses. Hydrate aggressively with plain water. Move directly to the intervention sequence I'm going to give you. And if any warning sign I name later develops over the next several hours, go to the emergency department and tell them what you took and when. The rule: any sudden liquid stool in the context of days without a bowel movement is overflow diarrhea until proven otherwise. The correct response is to address the impaction, not suppress the signal. Most people who come to me with a serious fecal impaction did not come on day 1. On average, they have been managing this alone for 4 to 7 days before calling. The reason is that bowel problems feel private in a way that almost nothing else does. For your generation, especially people who grew up handling things quietly, not wanting to be a burden. The idea of calling a doctor about this carries real weight. I understand that completely. But I need you to understand what that delay costs. At 3 days, the impacted mass continues to harden. The rectal wall is under sustained pressure. The window for straightforward home management is still open but narrowing. At 5 days, that window is closing. The tissue stress is increasing. What was manageable on day 2 is significantly less straightforward. Now at 7 days, rectal wall ulceration, actual tissue damage from sustained pressure, is a documented risk, and if the wall perforates, the resulting infection carries mortality rates in elderly patients that are sobering. The instinct that feels protective, trying one more thing before calling, is working against you on a measurable timeline. Every physician who treats adults over 60 has managed fecal impaction regularly. It does not require an apology. Calling your doctor is the correct clinical decision. The faster you make it, the simpler the solution. There is something in the medication routine of many seniors that is directly contributing to this problem. And in most cases, nobody mentioned it when the prescription was written. The one that concerns me most in clinical practice: opioid pain medications. Codeine, oxycodone, hydrocodone, morphine. Opioids bind to receptors in the gut wall directly. They suppress peristalsis at the source. Within 48 hours of starting an opioid, many patients experience a bowel that has not slowed but essentially stopped. Unless a bowel management protocol is started on day 1 of opioid therapy, impaction in a vulnerable patient is close to a certainty. If you are on any opioid and no one has prescribed a standing bowel medication alongside it, that gap needs to be addressed as soon as possible. Now the others, and I am naming specific medications because the category name alone often is not enough. Calcium channel blockers, amlodipine, diltiazem, verapamil, relax smooth muscle. The bowel wall is smooth muscle. It slows. Anticholinergic medications. Oxybutynin for bladder control, diphenhydramine in most over-the-counter sleep aids and antihistamines, certain older antidepressants. These block the nerve signals that drive bowel motility. Iron supplements harden stool through direct chemical interaction in the gut consistently in most patients who take them. Many seniors are on more than one of these simultaneously: an opioid, a calcium channel blocker, a bladder medication, and an iron supplement. Each one slows the bowel, and no one may have named that combination as a problem. None of these should be stopped without your physician's guidance. What needs to change is the absence of a bowel plan alongside them. At your next appointment, say this specifically: should I be on a standing osmotic agent or stool softener given my current medications? That is the sentence. Use it before the sequence. One thing first. When people reach the medicine cabinet looking for help, they usually find a stimulant laxative, senna or bisacodyl, the same thing that helped with ordinary constipation before. Against a hardened rectal impaction, that is the wrong tool. Stimulant laxatives trigger muscular contractions that push against a mass that cannot move. The result is cramping and urgency with no evacuation. Bulk-forming fiber at this stage adds volume to a system that cannot empty, worsening the blockage. The principle that governs everything that follows. Soften first, then move. You do not ask the muscles to work until the stool is in a state the muscles can actually engage with. Polyethylene glycol, sold as Miralax, is the first-line home intervention. It draws water from surrounding tissue into the colon. It does not stimulate contractions. It hydrates the mass from the outside in, reversing the dehydration that created the impaction. The dose: 1 capful 17 gram dissolved completely in 8 ounces of water taken once in the morning. This takes hours, not minutes. A single dose in the morning will not produce results by mid-morning. You are looking at that evening, at the earliest possibly the following morning, for a significant impaction. That timeline is expected. Do not conclude it is not working because nothing happened in 2 hours. Give it the full day. Milk of magnesia is the alternative if Miralax is unavailable. 2 to 4 tablespoons with adequate water, and this matters. Drink additional plain water throughout the day. The osmotic mechanism requires available fluid. 6 to 8 glasses is not optional. Alongside this step, it is part of the intervention. This is the step most people underestimate. In clinical experience, it is frequently the step that actually turns the situation. A glycerin suppository reaches the hardened mass directly at the site of the problem. It draws moisture in locally. It lubricates the surface of the mass where it contacts the rectal wall. That lubrication, the reduction of friction between hardened stool and tissue, is often what the body needs to finally make progress. The rectal muscles have been contracting against resistance. A lubricated interface changes that equation. Positioning matters here, and this is the detail most people are never given. Lie on your left side with your knees drawn up toward your chest. This is called the left lateral position. It places the lower colon in alignment with gravity and makes the suppository significantly more effective. Insert it and stay in that position for 15 to 30 minutes before attempting to use the toilet. The urge you feel during that time is the correct signal. Do not rush to the toilet before the 15-minute minimum. A mineral oil enema does the same work with greater volume and reach. Same left lateral position. The oil coats the surface of the impacted mass and the surrounding rectal wall, creating a slip interface the body's muscles can work with. For many patients, this is where the first real shift occurs. Not a complete resolution, a shift. Something begins to move that was not moving before. That is progress. Warmth relaxes the rectal wall muscle. Volume provides gentle pressure from above the impaction. Temperature is specific, approximately 98 to 100 degrees Fahrenheit. Not hot. Hot water damages rectal tissue, not cold. Cold causes cramping. Body temperature around 500 milliliters of volume. Same left lateral position. A note on phosphate enemas, the Fleet brand most people recognize. These carry real electrolyte risks in elderly patients, particularly those with any kidney impairment or heart disease. The phosphate can be absorbed through the rectal wall and cause dangerously elevated phosphate levels in the blood. Warm water or mineral oil is what I recommend for seniors, not phosphate. That guidance is explicit in geriatric care guidelines. Step 1 takes hours. Partial softening, a small amount of liquid stool passing, some reduction in the most intense pressure is the sign the process is working. It is not resolution. Begin step 2 while step 1 continues. If step 2 produces a shift but not full evacuation, that is progress, not failure. Some impactions require 2 to 3 sessions over 24 hours before full evacuation occurs. To anyone doing this alone, this process is uncomfortable. The pressure, the waiting, the uncertainty, that is real and expected. What would indicate something is wrong is the appearance of any warning sign I'm about to name. Everything else, discomfort, slow progress, is the process working on the correct timeline. If you are 48 hours into correct sequential management and nothing is moving, home management has reached its limit. Manual disimpaction is a clinical procedure. It is effective, routine, and definitively resolves what home management cannot reach. It requires no apology. It is simply the next rung on the ladder. There are 6 signals that tell you without ambiguity that this has moved beyond home management. Fever 100.4 degrees Fahrenheit or higher. In the context of fecal impaction, fever is a systemic signal that the bowel wall has begun to develop inflammatory change or early ischemia. Do not take acetaminophen and monitor overnight. Call your doctor or go to the emergency department. When you arrive, say, "I have been unable to have a bowel movement and I have developed a fever." Those 2 pieces of information together are what triage needs. Complete inability to pass gas. Difficulty is common. Complete inability, nothing at all for several hours or more, means the obstruction has extended beyond a rectal mass. This is functional bowel obstruction. This is an emergency. Rectal bleeding. Any blood beyond minor spotting, bright red, persistent, signals the rectal wall is under stress. It was not designed to sustain. Persistent bleeding does not wait for a morning appointment. Significant abdominal distension or rigidity. Lie flat. If the abdomen is visibly distended outward or feels hard and tender when pressed gently, the problem has extended beyond the rectum. The colon above is under pressure. This is not a home management situation. Nausea or vomiting, especially vomit with a fecal odor. If what you are vomiting has a fecal smell different from ordinary nausea, trust that signal immediately. A fecal odor in vomit indicates complete obstruction. This is an immediate emergency. No response to correct intervention after 48 hours. If the correct sequential protocol has been followed and nothing is moving at 48 hours, go. You do not need a dramatic warning sign. The absence of progress is itself the signal. Going to the hospital for fecal impaction is not the worst outcome. Waiting alone until something more serious develops is. Fecal impaction is the predictable outcome of manageable risk factors, and every one of them can be directly addressed. Here is the framework with the specificity that actually makes a difference. 6 to 8 glasses of plain water per day. It is the single most effective stool softener available without a prescription. Timing matters. A full glass of water first thing in the morning before coffee, before breakfast, activates the gastrocolic reflex. That is the physiological signal that tells the bowel the body is active and it is time to move. That morning glass is not just hydration, it is a bowel function trigger. Make it automatic. If you are on a fluid restriction due to heart or kidney disease, this needs to be individualized with your physician. If you're not on a restriction and you're not drinking adequate water, that is the first change before the fiber, before anything else. Psyllium husk is the most practical supplement form. 1 teaspoon dissolved in 8 ounces of water taken in the morning consistently. A bowl of oatmeal and an apple provides more than half of the daily fiber target without any supplement. Introduce fiber gradually. Adding large amounts suddenly to a compromised bowel causes cramping and bloating. 2 to 3 weeks of gradual increase is the correct approach. A 10 to 15-minute walk after breakfast is more effective for bowel function than a longer walk at an arbitrary time. The gastrocolic reflex is strongest following a meal. Movement after eating reinforces that signal. The walk after breakfast is bowel medicine. This one surprises most people, and the research behind it is legitimate. When the knees are raised above hip level, the puborectalis muscle relaxes more fully, straightening the anorectal angle and significantly reducing the straining force required. A footstool under your feet, 6 to 9 inches of elevation, achieves this on any standard toilet. For anyone who has been straining chronically, this single change makes a meaningful difference. Now let me make this practical because a framework that stays abstract does not protect you. 3 days without a bowel movement is the threshold for intervention. Not a week, not when the pain becomes unbearable. Day 3. Day 1 without movement. Note it. Increase water deliberately. Day 2. Add prune juice, or 2 to 3 prunes. The natural sorbitol in prunes acts as a mild osmotic agent. It works through the same basic mechanism as pharmaceutical osmotic agents at a gentler level. Day 3. Take Miralax, 1 capful in 8 ounces of water that morning. Do not wait for day 4. The osmotic agent taken proactively on day 3 prevents what would otherwise progress to impaction over the following 48 hours. The 3-day rule is not an alarm, it is a window. Acting within it keeps the situation manageable. Missing it narrows your options. If you are on opioids, calcium channel blockers, anticholinergic medications, or iron supplements, a bowel management protocol should be part of your treatment plan. If it is not, bring it up specifically. Ask, should I be on a standing osmotic agent or stool softener given my current medications? What matters is that a specific plan is in place, not an assumption that the condition is being managed without one. You came to this video with a problem most people manage alone in silence with the wrong information. You are leaving with the biology, the correct intervention sequence, the warning signs, and a daily prevention framework you can implement starting tomorrow morning. Fecal impaction is common, serious when handled incorrectly, manageable when caught early, and preventable when the right daily practices are in place. In the next video, we are covering another condition in this category, one where the gap between what most people are told and what the research actually shows is significant. Subscribe so you do not miss it. I will see you in the next.